Welcome to the deep dive. So, according to the research we're looking at today, about 63% of physicians actually practice at multiple locations.
Yeah, 63%. It's a huge number.
Right. So multi-site expansion in healthcare is, it's the absolute norm for you if you're a provider. And yet, despite it being this common, over half of healthcare organizations report losing revenue or facing just massive delays when they try to expand.
Which is wild when you think about it.
It really is. Imagine you're running a highly successful clinic. Demand is totally through the roof. Your patients love you. So you go out and you sign a commercial lease for a second location.
Makes sense. You're growing.
Exactly.
Yeah.
You hire the staff, you've got the keys in hand, and you are ready to double your impact. But opening those physical doors, it doesn't mean you can actually do business.
No, not at all.
Instead, you hit this invisible, highly bureaucratic wall.
Oh, yeah. And it's a wall built entirely out of, administrative portals, redundant forms, and just endless processing delays.
Yeah.
Like, you've got the building and you've got the doctors, but you don't actually have the permission to get paid for the clinical work you're about to do.
And that is our mission today. We are decoding the hidden labyrinth of medical credentialing. Specifically, why getting providers credentialed at a new location causes such massive revenue delays, and how the pros actually bypass these roadblocks.
It's such a crucial topic for anyone in the industry.
Definitely. And we're pulling our insights today from a really detailed industry article by Prime Credential. It's titled, How to Get Credentialed Faster When Opening a Second Location.
Mm-hmm.
Because right now, you've got these growing practices just bleeding money simply because the paperwork can't keep up with their physical footprint.
Yeah, they're physically ready, but administratively stuck.
Exactly. Okay, let's unpack this. Because before we can talk about fixing the delay, we really need to understand the mechanics of the delay itself.
Right. And what's fascinating here is that when we talk about this, paperwork bottleneck, we're actually looking at two completely distinct mountains of bureaucracy.
Two mountains.
Okay, yeah. People often use the terms interchangeably, but blurring them together is, well, it's the first strategic mistake a practice makes. We are dealing with provider enrollment on one side and payer credentialing on the completely other side.
Okay, so provider enrollment and payer credentialing. Right, and as I was looking through the source, it feels a lot like the difference between getting your state driver's license versus getting approved to drive for a specific rideshare company.
Oh, that is a great way to look at it.
Yeah, because provider enrollment is like the driver's license. You establish your legal authority to bill public health programs, like Medicare or Medicaid.
Exactly.
You register with the government, you prove you're a real clinic, and the state essentially says, yes, you are legally authorized to operate.
And then, just like that rideshare app, the private insurers want to run their own specific background checks.
Right.
And that's payer credentialing. So you're proving your qualifications to private insurers or managed care organizations, the MCOs. Getting the baseline legal authority to practice medicine does not automatically grant you access to, say, Blue Cross or Aetna's specific exclusive network of patients.
Because it's a private network.
Exactly. You have to prove you meet their corporate standards, that you carry the right malpractice limits, and that you actually fit into their business model. One proves you can operate legally. The other gives you permission to actually generate revenue within a private ecosystem.
But the timeline for getting that private permission is just staggering. The source notes traditional credentialing should supposedly take 30 to 60 days.
Supposedly being the key word there.
Right. Because they immediately warn it routinely stretches to 90 or even 150 days.
That's brutal.
That's up to 5 months of overhead costs, rent, payroll, utilities, all while you just wait for an insurer to say you can see their patients. I have to push back on this system, though.
Oh, I don't blame you.
Like, if a doctor's already legally practicing at their first location, they already have a driver's license.
Right.
They're already in the rideshare network at location A. Why on earth does it take 150 days to verify the exact same human being just because they walked into location B?
I know. It's the most common frustration for practice managers, but it really comes down to how insurers manage their financial risk.
Okay. How so?
Well, they aren't just credentialing the human being. They are credentialing that specific human being at a specific geographical location. Insurers are constantly assessing what they call network adequacy for every single zip code.
Network adequacy. Okay.
Yeah. They need to know exactly where the care is being delivered, what the local patient demographics are, what specific tax ID is billing them, and whether the local facility itself is properly insured. A new physical address triggers an entirely new corporate risk assessment from the payer's perspective.
Wow. So you really can't just send them an email saying, hey, Dr. Smith is also going to be working down the street on Tuesdays.
Oh, definitely not. You're essentially starting a massive corporate onboarding process from scratch.
Which means the only way to survive this without, bleeding out financially is to severely front-load the work.
Precisely. You have to approach this like compiling a watertight legal defense file.
Yeah, if you miss one piece of evidence, the judge, or I guess the insurer, throws the whole case out and you start all over.
That's exactly the level of rigor required. The preparation phase is just unforgiving. The source outlines this entire web of interconnected databases that have to be meticulously updated before you even submit a single application.
Like what?
Well, you've got CAQH, the Council for Affordable Quality Healthcare, which functions sort of like the master resume database for providers.
Okay, I've heard of that.
Yeah. Then you have PECOS, which is the federal government's specific portal for Medicare enrollment. You've got the NPES, the national system that assigns provider identifiers, plus, all the individual state licensing boards.
Right, and it's not just updating a digital profile.
Yeah.
You're tracking down physical documents that explicitly list the new site.
Exactly, the physical proof.
Malpractice insurance policies that specifically endorse the new address, updated board certifications, and, if the second site is a new legal entity, you need the corporate filings and EINs.
It's a mountain of paper.
It is. But as I read through this, gathering the paperwork actually seemed like the easy part compared to the structural puzzle you have to solve before you apply.
Yes. The NPI puzzle.
Yeah, the MPI puzzle. So what does this all mean?
Well, the National Provider Identifier Strategy is where the legal structure of your expansion directly dictates your revenue cycle. A practice has to decide how they're going to structure their business for billing purposes.
Okay.
And the article explains two main paths. You can either use one overarching group NPI, that's a type 2 NPI, and create subpart NPIs for each physical location.
Right.
Or you can set up completely separate legal entities with completely distinct tax ID numbers, or TINs, for every single clinic.
Structurally, it sounds exactly like deciding whether you're going to operate your new clinic as a franchise branch of your main brand, sharing the same corporate umbrella,
Yeah.
or if you're setting it up as a completely distinct, wholly owned subsidiary with its own isolated books and tax identity.
That's the perfect way to conceptualize it. And the reason this choice is so critical is that it fundamentally changes how insurers route your money.
Wow, okay.
Yeah, if you get it wrong, the downstream effects are catastrophic. The source points out that certain insurers flat out demand a distinct enrollment and a distinct NPI for every single tax ID and office location.
Which means if you try to streamline things by using one group MPI for all your locations, but an insurer's internal policy requires separate ones to isolate malpractice liability or track regional profitability.
They just reject your claims.
They just reject them.
Yeah.
The money gets misdirected, your claims come back as unrecognized provider location, and you are forced to restart a 150-day process while your clinic is fully staffed and just sitting empty.
Exactly. You are hemorrhaging cash because of a structural formatting error.
That is terrifying.
It is, which is why the guidance relies heavily on strategic sequencing. You can't just blast out applications. You have to research every single insurer's specific structural demands and network status in your new service area before you submit anything.
And that leads to a really aggressive strategy mentioned in the text. Because when you audit an insurer's market data, you might find they claim their network is closed in your new zip code.
Yes, the dreaded closed network.
Right. They might say, we have enough therapists here, we aren't accepting new clinics. You're basically flying blind unless you push back with your own data.
You have to be ready to fight for an exception. If they claim a closed network, the playbook says you counter them with hard provider-to-population ratios.
So you bring your own stats.
Exactly. You bring demographic data highlighting the desperate need for your specific medical specialty in that exact neighborhood, basically proving their network isn't actually as adequate as their internal spreadsheets claim it is.
It is wild to me that a healthcare clinic has to audit an insurance company's own demographic data just to get permission to treat local patients.
It's backwards, but it's the reality.
But, okay, let's assume you do everything perfectly. You sequence your MPIs correctly, you update CAQH, you compile the perfect legal defense file of documents. As we established earlier, perfect paperwork still just sits in a digital pile for 5 months.
Unfortunately, yes.
So how do you force that pile to move faster? Well, here's where it gets really interesting, because the source dives into how the industry is finally trying to cheat that clock using technology.
And the accelerator pedal is definitely being pushed here. Modern tools are stepping in to bypass the manual data entry phase, which is historically where the most fatal errors happen anyway.
Right, because of typos. And the major leap mentioned here is a tool from the American Medical Association called Veriker.
Yes, Veriker.
What it does is integrate AMA-verified provider data directly into the credentialing software. I mean, think about the old way. Someone is manually transcribing a doctor's 20-page CV, decades of educational history, previous addresses, and license numbers into a clunky web portal.
It's a nightmare.
Yeah, and if they make a single typo on a medical school graduation year, the application gets kicked back weeks later.
Exactly.
But Veriker pre-populates about 50% of the required application data instantly from the AMA's primary source.
And the operational shift there is massive. The article notes it cuts manual entry time from hours per provider down to just 15 or 20 minutes.
That is a huge time saver.
Right. Pre-filling data from a verified, trusted source eliminates the human transcription errors that cause the majority of those frustrating 30-day delays for minor typos.
But, technology only solves the data entry side.
Yeah.
It doesn't actually force the insurer's review committee to meet any faster.
That's a very fair point.
The other half of the solution is what looks like a legislative cheat code: expedited credentialing pathways that are mandated by state law.
Yeah, the source highlights a phenomenal example out of Texas. Texas law mandates that managed care organizations must provisionally credential certain licensed therapists immediately upon receiving a complete application.
Wait, immediately, not 150 days.
Immediate provisional status. It specifically applies to LCSWs, LPCs, LMFTs, and psychologists. If your clinicians fall into those categories and your paperwork is flawless, the MCO is legally forced to treat them as in-network.
Oh, wow.
Yeah, they have to begin paying out claims at in-network rates within about 30 days while they finish their formal background checks. They don't get to drag the process out and starve the practice of revenue.
Which naturally makes you wonder, right? If we have technology like Veriker cutting paperwork to 20 minutes, and we have states like Texas proving you can legally mandate a 30-day turnaround for therapists without the system collapsing,
Right.
why is the rest of the healthcare industry still tolerating a 150-day standard?
Well, it comes down to a deeply fragmented regulatory landscape and, frankly, misaligned financial incentives.
Stop it.
Always. Texas implemented that law for specific mental health professionals, but step across the border or try opening a cardiology clinic, and those protections vanish entirely. And absent a state law forcing their hand, insurers just don't have a strong financial incentive to speed up the process.
Because they keep the money longer.
Exactly. Every single day a provider sits in credentialing purgatory is a day the insurer doesn't have to pay out a higher in-network claim. They hold on to that cash flow longer. Upgrading their internal processing systems to move faster actually costs them money twice.
How so?
Once for the software upgrade, and again in faster claim payouts.
Wow. So if you aren't protected by a specific state law, you are left fighting a bureaucracy that has an actual financial disincentive to process your paperwork quickly.
Precisely.
The technology is there, the laws exist in pockets, but the final hurdle to getting that second location open is overcoming sheer bureaucratic silence.
And this raises an important question. How do practice managers realistically handle this concurrently while trying to run their original location?
Yeah, they still have patience to see.
Because the clock isn't just ticking on their cash flow, it's ticking on federal compliance.
Right, the 30-day Medicare rule.
Yes.
The source really emphasizes this. When you open a new clinic, you must report the new practice address to Medicare within 30 days. It's a strict anti-fraud measure.
Very strict.
If you miss that window, you are looking at severe compliance penalties and potentially having your existing billing privileges revoked entirely.
And Medicare applications are processed by regional bouncers, basically. They're called Medicare Administrative Contractors, or MSCs.
Okay.
You're dealing with them through the PECOS portal while simultaneously juggling all the private MCOs. You can't submit an application and just wait for the mail.
No.
The follow-up protocol, detailed in the text, requires assigning dedicated personnel to reach out every single week.
Every week.
Weekly calls to the payer credentialing departments. Weekly check-ins with your MSE. You log reference numbers and document every single conversation until you finally secure the official welcome letter confirming the new location is approved.
That takes an immense amount of human capital. which is why the article breaks down how specialized third-party services operate in this space.
Right.
We're looking at the playbook from Prime Credential, as detailed in their text, to understand how the industry scales this. They use proprietary tracking software and dedicated account specialists to manage this massive headache. But the real strategic advantage they highlight is concurrency.
Yes, concurrency is the only way to compress the timeline.
Yeah.
A specialized approach means managing the Medicare, Medicaid, and all the various commercial applications in parallel rather than sequentially.
Oh.
You don't wait for the state to approve your Medicaid enrollment before you start pitching the private MCOs.
You do it all at once.
You process them all simultaneously using established pre-flight checklists so nothing stalls out.
It's kind of like, it's exactly like how students tackle modern college applications.
Oh, that's a good comparison.
Yeah. You don't apply to one university, wait 3 months for a rejection letter, and only then start uploading transcripts for your backup school. You lose a whole year.
You never get in anywhere.
Exactly. Instead, you use the Common App. You front-load your essays, you upload your transcripts once, and you hit submit on all the online portals at the exact same time. You force all the institutions to evaluate you concurrently.
And that concurrent pressure, combined with absolute organized persistence, is what gets a new clinic across the finish line.
Right.
Whether a practice builds that capability internally with meticulous spreadsheets and weekly call logs, or they outsource it to a dedicated team, the underlying mechanism for survival is exactly the same. You have to aggressively manage the timeline because the timeline won't manage itself.
It's incredible how much friction exists in what should, theoretically, be a simple address update for an already practicing doctor.
It really is.
But bringing this back to you, the listener, if you're a healthcare provider staring down a commercial lease and wondering how to scale your practice without bankrupting yourself in the first 6 months, understanding this credentialing bottleneck is absolutely critical.
Essential.
Or even if you're just a patient wondering why it takes 3 months to get an appointment at that brand new clinic down the street, this exposes the hidden gears of the healthcare system. The delays in patient care are rarely about a lack of physical doctors. They're almost always about a lack of administrative processing.
It completely reframes how you look at healthcare expansion in your community. And I want to leave you with a final thought to mull over, building on the reality of those delays.
Okay.
We know tools like Vericur can pre-populate half a provider's data instantly from the primary source. We know states like Texas have legally proven that insurers can easily process and provisionally credential applications in 30 days when mandated to do so.
Right, the tools are there.
So you have to ask yourself, is this massive 150-day waiting period still genuinely a technological limitation of an overwhelmed system? Or has it quietly evolved into a deliberate administrative tool used by insurers to intentionally gatekeep their networks and delay paying out claims?
Wow. That definitely changes how you look at the system. Because it turns out signing the lease and getting the keys to the new building is the easy part. Convincing the corporate ecosystem to actually let you treat the patient standing outside your door, that's what takes 5 months. Thank you for joining us for this deep dive. We'll catch you next time.